All right, welcome to your deep dive
Yeah.
into two, I think, really fundamental areas of orthopedics that you're going to need to have a really good grasp of, especially as you guys are all preparing for your FRCS exams and things like that.
Huge topics.
Yeah, absolutely.
Yeah.
So we're going to be talking about compartment syndrome and all its nuances.
Yes.
And then the principles of traction.
Some applications.
Yeah, exactly.
Yeah.
And just to let you guys know, this deep dive is based on the Ortho Made Simple notes from mokyingren.sg, which is a website compiled by Dr. Mok Ying Ren, who's a sports surgeon from National University Hospital in Singapore, who did his FRCS in 2022.
Yeah.
So you guys have all seen this, encountered this in your training.
All the time.
But we're just going to go through sort of like the key things that you need to really
Distill it down.
Yeah, exactly.
Yeah.
So shall we jump straight in with compartment syndrome then?
Let's do it.
So what is it?
Okay, so compartment syndrome. Basically, it's when you have this closed space, right? A closed osteofascial compartment in a limb.
Right.
And the pressure inside that compartment, it builds up so high that it actually surpasses the pressure that's needed for the tissues to actually get blood flow.
Yeah.
So you're basically cutting off the blood supply to the muscles and the nerves in that area.
And that's bad.
And that's very bad.
Yeah, for sure.
Yeah, so you don't want to miss it.
No, absolutely not.
Pick it up early.
So let's say you suspect compartment syndrome in a patient. What are the objective markers that you're looking for to diagnose it?
So there's two main criteria that you should know.
Okay.
And the first one is if you actually measure the compartment pressure.
Yeah.
If it's 30 millimeters of mercury or more, that's compartment syndrome.
Okay.
Right. So that's quite high.
30 or more.
30 or more.
Yep.
The other one is a differential pressure. So you take the patient's diastolic blood pressure.
Right.
And you minus off
the
compartment pressure that you've just measured.
Okay.
If that difference is 30 millimeters of mercury or less, that's also compartment syndrome.
Okay, so it's either absolute or...
That's right.
The difference.
The difference.
Got it.
Yeah, and this is based on a paper, McQueen, 1996.
Okay.
JBJS.
Okay.
Which actually compared both these criteria.
Right.
And they showed that actually if you just use the absolute criteria, 30 millimeters of mercury, you would actually end up missing some patients who have compartment syndrome.
Okay, so...
That there are, some issues with this.
Yeah.
And I think clinically we have to, use our judgment as well.
Of course.
And not just rely on these numbers blindly.
Yeah, for sure. And these notes kind of skip over that a bit, I think.
Yeah.
So,
it's not, black and white.
Yeah, exactly. Yeah. So
this is where experience and, seeing patients and, and that clinical acumen comes in, I think.
Yeah, for sure. And that's what these exams are trying to test, right?
Exactly.
Okay, so the lower limb, the calf, is like a really common place for compartment syndrome.
Very common.
So if you, suspect it and you want to actually stick a manometer in, where do you put it?
So in the calf, you want to be within 5 centimeters of the fracture site.
Okay.
That's where the swelling is going to be the most.
Yeah.
And the most important thing is you have to check every single compartment.
Okay.
So you can't just put it in one place and be like, oh, it's normal, we're fine.
Yeah, got it.
Because there's 4 compartments in the calf.
Okay, so remind me, what are the 4 compartments?
Okay, so the 4 compartments are...
And what's in them?
Yeah, so the anterior compartment, that's the one at the front, right? And that's got the muscles that lift your foot up, so tibialis anterior, extensor hallucis longus, extensor digitorum longus, as well as the anterior tibial artery, and the deep peroneal nerve.
Okay.
Okay, so if you get swelling there, the patients can't lift their foot up.
Yeah.
They might lose sensation on the top of their foot, in between their first and second toe.
Right.
You might even lose the dorsalis pedis pulse.
Okay, so it's a big deal.
Yeah.
Okay, what about the next one?
Okay, so the next one is the lateral compartment, and that's got peroneus longus and brevis, and the nerve that supplies them is the superficial peroneal nerve.
Right.
And that's mainly for turning your foot outwards.
Okay.
Right.
Got it.
And then the big one really is the deep posterior compartment. And this one's got tibialis posterior, flexor digitorum longus, flexor hallucis longus, as well as the posterior tibial artery and the tibial nerve.
Okay.
Okay, so that's a really important one. And then finally you have the superficial posterior compartment. And that's got gastrocnemius, soleus, and plantaris.
Yeah.
And the nerve there is the sural nerve.
Okay. And that one, mainly sensation.
Yeah, sensation to the outside of the foot.
Yeah. Okay. And I remember reading in these notes something called the soleus bridge.
Uh-huh.
What's that?
So the soleus bridge, it's basically this archway that the soleus muscle makes where it attaches to the tibia.
Okay.
So it kind of goes from the medial edge of the tibia and it bridges over the posterior tibial vessels and nerve.
Right.
And that can be a bit tricky when you're doing a fasciotomy because you have to make sure you release that as well.
So you have to cut through it.
You have to divide that bridge. Otherwise, the pressure in the deep compartment might not be fully released.
Okay, so you're basically aiming to see the back of the tibia.
Yeah, you want to see the bone to make sure you've released it properly.
Yeah.
And if you are doing a calf fasciotomy, what's the approach?
So the notes talk about the Bapparas guidelines, which recommend a 2-incision technique.
Okay.
So you make 1 incision on the inside, and that's about 1.5 centimeters behind the medial border of the tibia.
Okay.
But the key thing here is you want to be careful of the perforating vessels.
The perforators.
Yeah, they come through the fascia to supply the skin, and they're usually about 5, 10, and 15 centimeters above the medial malleolus.
Right.
So you want to avoid those.
Got it. And then where's the other incision?
The other incision's on the outside, and that's about 2 centimeters lateral to the front edge of the tibia.
Okay. Yeah. And that gets all 4 compartments?
Yep. That should decompress all 4 compartments.
Okay.
Yeah.
And what about closure?
So closure can be a bit tricky after fasciotomy because everything's so swollen.
Yeah.
Sometimes you can't close it straight away.
Right.
One option is to close one side primarily.
Okay.
Maybe the medial side.
Where the swelling's not so bad.
Yeah.
And then put a split thickness skin graft on the other side.
Right. Okay.
Later on.
Yeah, I've seen that.
Yeah. The other option is this cool technique called dermatotraction.
Okay.
So you basically take vessel loops.
Yeah.
And you put them across the wound edges like shoelaces.
Right.
And you can kind of gradually tighten them
okay.
over a few days. And that helps to bring the skin edges together.
Okay, clever.
Yeah.
Yeah, okay. What about the thigh then?
So the thigh, you've got 3 main compartments.
Okay.
So you've got the medial compartment, and that's where your adductor muscles are. So adductor magnus, brevis, longus, and gracilis.
Right.
And you've got the deep femoral vessels and nerve running through there.
Okay.
And then you've got the anterior compartment, and that's your quads, so rectus femoris, vastus medialis, lateralis, intermedius, sartorius as well, and the femoral vessels and nerve are in there.
Okay.
And then finally, you've got the posterior compartment, and that's your hamstrings, so semimembranosus, semitendinosus, biceps femoris, and the sciatic nerve.
And the fasciotomy for the thigh, it's usually just a medial and lateral incision.
Yeah, so you make a long incision on the inside and the outside. Yeah. And that will decompress all 3 compartments.
Okay, simple.
Yeah.
Okay, now the foot, everyone gets confused about.
The foot is a nightmare.
It's a nightmare. Yeah, how many compartments are there?
So it's been debated, but the current consensus is 9.
9.
Yeah, 9 compartments.
Wow, okay. Remind me.
Okay, so you've got 4 enterossae compartments.
Okay.
You've got a medial compartment, which is where your abductor hallucis and flexor hallucis brevis are.
Right.
You've got a lateral compartment, which is abductor digiti minimi and flexor digiti minimi brevis.
Okay.
You've got a superficial compartment, and that's where all the flexor tendons and lumbricals run.
Right.
You've got the adductor compartment, which is the adductor hallucis. And then you've got the calcaneal compartment, where quadratus plantae is.
Okay. 9 compartments.
9 compartments in the foot, yeah.
Okay, that's a lot.
It is a lot.
So how do you do a fasciotomy there?
So there's this technique called Meyerson's 2 dorsal approach.
Yeah.
And basically you make 2 incisions on the top of the foot.
Right.
One over the 2nd metatarsal and one over the 4th metatarsal.
Okay.
And that allows you to release the introssae compartments, the lateral compartment, the adductor compartment, and the superficial compartment.
Okay, so that's quite a lot.
Yeah, and then usually you need to do a medial incision as well.
Right.
To get the medial and calcaneal compartments.
Okay.
Yeah.
And what about people talk about like the risks of foot fasciotomy.
Yeah, foot fasciotomy is it's a bit controversial, I guess.
Yeah.
Carries quite a high risk of infection.
Right.
Because you're making all these incisions in the foot. And it often needs like soft tissue coverage afterwards.
Right.
And the other thing is, even if you don't do surgery, patients with foot compartment syndrome, they can still end up with these like claw toes and cavus foot deformities.
Really?
Yeah, because the muscles get ischemic and fibrotic.
Oh, wow. Okay, so even without the surgery, it can still go wrong.
Yeah, so it's a tough one.
Yeah.
There's a paper from the Journal of Foot and Ankle Surgery.
Okay.
By Han Fukai.
Okay.
Et al. In 2015, which suggested that if you can release the compartments within 4 hours of the onset of the symptoms, you get much better outcomes.
Okay, so the timing.
The timing's critical.
Is key.
Yeah.
All right. So that's the lower limb.
Good.
What about the upper limb then?
Okay, so the upper limb.
Forearm, I guess?
Forearm.
Yeah.
How many compartments?
3 compartments in the forearm.
Okay.
You've got the volar compartment.
Yep.
Or the flexor compartment. And that's got a superficial layer and a deep layer.
And then you've got the dorsal compartment or the extensor compartment. And then you've got this thing called the mobile wad, which is basically brachioradialis and the wrist extensors on the radial side.
And the release there, it's, I guess, a Henry's approach or a Thompson approach?
Yeah, so you can do a Henry's approach, which is like a curvilinear incision.
Yeah.
Or you can do a Thompson approach, which is a posterior incision.
Okay.
Yeah.
And the hand, I guess, is similar to the foot.
Yeah, the hand's also got 10 compartments.
10 compartments?
10 compartments, yeah.
Okay, so what are they?
So you've got 4 dorsal interosseous compartments.
Yep.
3 palmar interosseous compartments.
Okay.
The adductor pollicis compartment. The canard compartment.
Yeah.
And the hyposynar compartment.
Okay.
Yeah.
And fasciotomy there.
So fasciotomy for the hand, it's kind of similar to the foot.
Right.
You can do Meyerson-type incisions over the 2nd and 4th metacarpals. And then you do medial and lateral incisions as well.
Okay, so medial to get the...
Yeah, to get the renar and the adductor pollicis, and lateral to get the hypothenar.
Okay.
Yeah.
All right, so that's
compartment syndrome.
Compartment syndrome, yeah. Let's move on to traction then.
Okay.
What are the different types of traction?
Okay, so traction is mainly divided into 2 categories.
Okay.
Fixed traction and sliding traction.
Okay.
Or balanced traction.
Got it.
So fixed traction, it's where you're applying a force to the limb that you want to distract.
Yeah.
And you're using another part of the body as the counterforce.
Right, okay.
So an example of that would be like the old Thomas splint.
Yeah.
Okay. Whereas sliding traction, you're using the patient's own body weight as the counterforce.
Okay.
So examples of that would be like gallows traction, halter traction, Hamilton-Russell traction.
Got it.
Yeah.
And are there like specific types of traction for specific fractures?
Yeah.
So there are, right?
For example, if you've got like a proximal femur fracture or an acetabular fracture, then you might use Hamilton-Russell traction.
Okay.
If you've got a femoral shaft fracture and there's no knee injury, then you might use a Thomas splint.
Right.
But if there's a distal femur fracture, then you'd add a Pearson attachment to the Thomas splint.
Yeah. Okay. So can you talk a bit more about Hamilton-Russell traction? How does that actually work?
Okay. So Hamilton-Russell, that's for proximal femur and acetabular fractures, like I said.
Yep.
And it's a balanced traction system. So the patient's own body weight is used as the counterforce.
Yeah.
And it's got this clever system of pulleys, which they call force doubling by block and tackle effect.
Yeah, I remember that from physics.
Yeah.
Yeah.
And so basically you've got like 5 pulleys.
Right.
And the way the ropes are arranged, it actually doubles the force that's applied.
Right.
And the resultant force, it's actually aligned with the femur.
Okay, so it helps.
So it helps to reduce the fracture.
Clever.
Yeah.
Okay, and what about the Thomas splint? I mean, everyone knows what a Thomas splint is, but...
Everyone's seen it.
Yeah.
Yeah.
But how does it work, really?
So the Thomas splint...
I guess it's fixed traction, right?
It's fixed traction.
Yeah.
So that ring at the top, it pushes against the ischial tuberosity.
Right, to get a good grip.
Yeah, so that's your fixed point.
Okay.
And then the traction force...
Yeah.
It's applied distally to the limb.
And that's basically just pulling along the line of the femur.
Yeah. So you're basically distracting along the axis of the femoral shaft.
Got it.
Yeah.
And the Pearson attachment.
So the Pearson attachment, that's added if there's a distal femur fracture.
Yeah.
And basically what it does is it allows you to bend the knee.
Okay.
And that relaxes the gastrocnemius muscle.
Right.
Which can sometimes pull on the distal fragment.
So it stops it from displacing.
Yeah, it helps to prevent displacement.
That's,
Yeah.
Clever.
Yeah.
And gallows traction, that's the one for little kids, right?
Yeah, gallows traction, that's for kids under 1 year old with femoral shaft fractures.
Right, and it's balanced.
It's balanced.
Yeah.
So they're basically lying in bed
Yeah.
with their legs up in the air.
Right.
And you have to be careful with the weight.
Okay.
You don't want to put too much weight.
So how much is too much?
Usually it's about 10 pounds maximum.
Okay.
And you have to check their skin really carefully.
Yeah. I guess that's important with kids, right?
Yeah. Their skin's very delicate.
Yeah.
So every 48 hours, you want to check the skin.
Got it. All right. And Dunlop's traction, I've seen that one.
Dunlop's, yeah.
What's that for?
So Dunlop's is for kids with supracondylar humerus fractures.
Okay.
So it's basically like skin traction on the forearm, with the traction force going along the upper arm.
Right.
And the elbow's usually bent to about 45 degrees.
Got it.
Yeah.
And what about traction for the neck?
So for the neck, we use halter traction.
Halter traction, yeah. And that's balanced as well, right?
It's balanced, yeah.
Okay.
So you have this chin strap, which is attached to a rope, and the head of the bed is raised up.
Right.
So the patient's own body weight provides the counter traction.
And that can be used at home.
Yeah. The good thing about halter traction is it can be used at home.
Yeah, okay.
As well as in the hospital.
Got it. And the weights are quite light, right?
Yeah. Usually you only need like 5 pounds or so.
Okay.
And we often give muscle relaxants and painkillers as well.
Yeah, to help with the spasm.
Yeah.
Yeah. Okay. And sometimes skin traction's not enough, right?
That's right.
So you have to put a pin?
Yeah. Skeletal traction.
Skeletal traction,
Yeah.
So where do you put the pins?
So for the femur, you usually put the pin in from the medial side to the lateral side.
Okay.
And that's to avoid the neurovascular structures on the medial side.
All right. So medial to lateral?
Yeah.
And where on the femur?
So you want to put it just above Blumensaat's line.
Blumensaat's line, which is...
so that's basically like the roof of the intercondylar notch.
Okay, got it.
And the pin size is usually 6 millimeters.
Okay.
And the weight you put on is about 20 pounds.
20 pounds, okay.
Yeah.
And the tibia.
So for the tibia, you put the pin in from the lateral side.
Okay.
And that's to avoid the common peroneal nerve.
Right. So lateral to avoid the common peroneal nerve.
Yeah.
Okay.
Yeah.
Got it. And what's the difference between a Steinman pin and a denim pin?
So Steinman pin is completely smooth.
Okay.
All the way along.
Yeah.
A denim pin, it's got threads in the middle.
Okay.
So that's designed to be used in the calcaneus.
Okay. So the threads grip the bone better.
Yeah, they grip the cancellous bone better.
Got it.
Yeah.
Okay. So, wow, I think we've covered quite a lot.
Yeah.
Gone through compartment syndrome in detail.
Yep.
All the different compartments.
Upper limb, lower limb, lower limb.
Yeah. And then the principles of traction, fixed and sliding, all the different types of traction.
Yeah, the indications.
Yeah. So this has been, just a reminder, this is all based on the Ortho Made Simple notes from the website.
Yeah.
mokyingren.sg.
By Dr. Moki.
Yeah. So I think, as you guys are all preparing for your exams, I think the real take-home message is that both compartment syndrome and traction, they can go wrong.
Yeah, they can.
Really wrong.
Yeah, they can have serious complications.
Yeah. So how are you gonna apply this knowledge to real life situations, maybe in your exams, but also when you're actually out there, on call.
Yeah, when you're the one making the decisions.
Yeah.
Yeah, it's a lot of responsibility.
Yeah, food for thought.
Yeah, definitely.
Okay, thanks so much.
All right, cheers.